Hello, my name is Dr. Audrey Cook, and I would like to welcome you to Cooking with Fluids. This is a short series of videos that helps explain how I think about making a good and safe fluid plan. I've called this first lesson the big picture, because what we're going to do in this little segment is think about the really major ideas that we use to make a smart fluid plan. Now, the first question we always need to ask is, why are we reaching for a bag of fluids? What does this animal actually need? And when I say fluids, I'm really talking about any non-biological solution in a plastic bag. So first thing we have to do is really clearly identify our patient's needs. And the reasons for that is that a poorly planned fluid therapy can actually be harmful. What I want to do is introduce you to what I call the 3 circles parts 1 and 2. And these are just very simple models that I reach for all the time to try and organize my thoughts. By thinking in terms of my 3 circles parts 1 and 2, I can reliably identify my patient's needs, and this lets me direct much more intelligent fluid planning. So here we go, the circles. Part 1, what exactly are the problems? Why am I reaching for fluids? And a shout out here to the late, great Dr. Steve Haskins, who's the first person I heard use this model. So looking at a patient, we have to decide why we're giving them fluids. Are we dealing with a crystalloid loss? Is this a patient who's got vomiting or diarrhea or polyuria, polydipsia? Very, very common reason for us to give fluids. Or we're looking at a patient who's got a colloidal issue. So this would be a patient who's got a low total proteins. The albumin is less than 2.5. They're actually not able to hold fluids appropriately because their colloids are low. Or do we have that rare patient who has what we call a sodium-water imbalance, in which the normal relationship between salt and water has become deranged? Really important to establish which one we're looking at, because it's going to change our planning. Something else to bear in mind is that our patients may actually have a foot in 2 spots. They may have a crystalloid loss and a colloidal issue. You may be very unlucky and have a patient who's got all 3, but that mercifully doesn't happen very often. I want to talk first about crystalloid loss, because this is by far the most common reason why we administer fluids to our patients. Now, you're going to be able to identify a patient who's got a crystalloid loss most often based simply on history and physical exam. So this is inevitably somewhat subjective. There really isn't any firm way to determine a patient's hydration status. It's always going to be a very personal assessment. Now, lab data can certainly support our evidence that we think a patient has a crystalloid loss, but ultimately we've always got to rely on our own clinical judgments. When it comes to recognizing patients who've got colloidal issues, this is an awful lot easier, because for these patients, we can rely very accurately on our lab work. If you can, it's always nice to look at an albumin, but a total protein is also a very, very good guide. If total proteins are fine, you can pretty much presume that albumin is going to be okay, in which case the patient does not have a colloidal issue. You do have to bear in mind, though, that things can change. If a patient presents very, very dehydrated, their albumin may be okay at the start, but may drop to dangerous levels once you've restored their volume loss. Now, patients with sodium-water imbalances are luckily uncommon, because they are kind of scary. And again, we're going to recognize these patients based on lab data. If there's one electrolyte that I really can't reliably predict and would actually personally pay to get before I did a fluid plan, it would be sodium. If the sodium is between 130 and 160, then the patient does not have a sodium-water imbalance. But if the sodium is less than 130 or greater than 160, this patient does. Now, if you have reason to believe that this sodium has been outside of this important range for more than 24 hours, then you've got potentially a problem on your hands. Best thing to do is call a specialist. We're going to move on to circles part 2, and this really applies to what are the very specific needs for this patient and really reflects their crystalloid issues. Again, we've got 3 circles, just arranged a bit differently. In the middle, we have the maintenance circle. Every patient has a maintenance fluid need. The Second circle is the replacement fluid need, because many of our patients who are getting crystalloids have a replacement fluid need. And then the third circle is the resuscitative fluid need. That doesn't apply to everybody. That's going to be a judgment that we need to make. Does this patient show us that they actually need to be resuscitated? If we are maintaining, we should actually ideally use a maintenance or M fluid. If we are resuscitating or replacing or restoring, then we need to use an R or replacement fluid. So I want to go ahead and clarify what I mean when I say a maintenance fluid versus a replacement fluid, as this sometimes causes confusion. The one property of a fluid that determines if it's an M versus an R is simply its sodium concentration, and that is going to be written on the fluid bag. Now, a maintenance fluid is designed to essentially mimic what is lost across the respiratory and urinary tracts, whereas replacement fluids have a sodium concentration that is significantly higher. The sodium concentration of replacement fluids is essentially the same as the sodium concentration of our plasma, and these fluids are designed to restore losses and are used for resuscitation. I want to take just a moment to make sure we're all on the same page when we talk about maintenance versus replacement. When we think about what it takes to just simply stand still, actually think about the fluid that leaves our body over the course of 24 hours. Most of that fluid loss is going to be across the respiratory tract, and that is a pure water loss. We're also going to lose some volume, obviously, of fluid through our urine. That actually contains a pretty modest amount of sodium. So if you think about the fluids that come off of our body over a 24-hour period, it's actually got a relatively low sodium concentration. And that's why maintenance fluids have a sodium concentration of about 30 to 40 millimoles per liter. It's designed to reflect what we lose under normal circumstances. You can think of a maintenance fluid as being mostly water and just a pinch of salt. A replacement fluid is used to restore lost plasma volume. We also use these fluids we are resuscitating a patient. And so the content of a replacement fluid should basically be the same as the watery part of plasma. So our fluids contain a lot more salt. They contain a sodium that's about the same as plasma, so between 130 and 154 millimoles of sodium. So a lot more salt compared to the amount of water. We're going to talk a lot more about exactly how we use fluids in the next little videos. So the take-home messages from today really are about the basics. We want to go ahead first and define our patient's problems. We then want to go ahead and make sure we've identified our patient's needs. When we've figured all that out, we can go ahead and grab a bag of fluids and get started. So do join me in the next little videos as we take it to the next step.